Okay, so now getting back to general joint flow, we have joint alignment covered, we have nerve supply covered, okay? The next thing you want to do, then you start going to the local muscle itself to see what's going on in the muscle. So say we're working on a deltoid or whatever, if we're working on a quadricep, whatever it's going to be, then you want to just see which muscles are weak, which are strong, okay? Um, if there's an injury to the joint, usually it's going to be an origin or insertion. Some other things could be going on there too. But if there's a shearing injury, you got to take a history. So, was there ever an injury to the joint? What kind of injury was it? What happened? If there's not an injury to the joint, you want to look to the 5 factors of the IVF. That's what you want to do. But if there's actually joint injury, you want to see how the joint was injured. You want to take a good history. You want to kind of figure out how it was done. If there was a shearing injury, there's going to be a weak muscle. It could be more than one weak muscle, but you're going to look for weak muscle or muscles with an origin insertion problem. So therapy localize the origin insertion, see if that strengthens the muscle. This is the original origin insertion technique that Dr. Goodhart discovered back in 1964. The first AK technique there was, still super powerful, super potent, and something you really have to do if you're going to be really getting people well. So origin insertion technique, just perpendicular pressure, pushing the muscle back onto the periosteum. It's going to be a little bit tender. You're going to feel a little bit inflammation there where the separation is. Just do some rotatory pressure for about 30 seconds or so, and then recheck the muscle, and then therapy, if the muscle's strong, have the patient therapy localize the origin insertion again to make sure that it is 100% complete. If it goes weak again with therapy localization, then you go and do the technique again. So after origin insertion, the next big thing you want to go to and look at is going to be spindle cells. If a muscle is weak, have the patient therapy localize the belly of the muscle and see if that strengthens it. And that can be an indication that spindle cells are set too low. To set the spindle cells up higher again, you get in the belly of the muscle and you're going to stretch out the belly of the muscle with some firm pressure, and that should turn the muscle back on. Now, the other reason, there's 3 big reasons why a muscle could be weak. The third one is going to be Golgi tendon organs. Now, these are in the tendinous parts of the muscle. Have the patient therapy localized by the tendinous parts of the muscle, not quite at the origin insertion, but a little bit more proximal to the belly of the muscle. And if that strengthens the muscle, you're going to push with firm pressure the tendon areas of the muscle, the Golgi tendon organs, toward the belly of the muscle, and that will strengthen the muscle. So 3 big reasons why a muscle is going to be weak. Origin insertion, by far your most common reason. Spindle cells. And number 3 is going to be the Golgi tendon organs. Once you correct the weak muscles, now we got to go and find out what else is going on. If you have a weak muscle in any area in the body, especially with the shearing injury type injury, you're going to have some other areas that have tightened up. Number 1 is the antagonist to the weak muscle. So test antagonists to weak muscles. It should be strong. Give it a gentle stretch. If it weakens, that's an indication for a fascial flush technique. So you're going to fascially flush that muscle firmly, do a Rolfing type of treatment toward the heart. Do that for about 30 seconds or so and retest the muscle. It should be strong and clear. You stretch it and then it'll create a weakness. If that weakness is gone, once you stretch it, you've corrected the fascial flush. From there, next step, you want to go and check the synergist to the original weak muscle we found. You want to check it for a strain counterstrain. So the synergist should be strong and clear. And then what you're going to do is do a 3-second maximum contraction in the muscle test. Have the patient hold for about 3 seconds, and then let it totally relax and go back to its normal relaxed state, and then retest the muscle again momentarily afterwards. And if that creates a weakness, it's an indication for strain counterstrain. Now, what you want to do is find the trigger point in the muscle, the belly of the muscle usually, and you're going to shorten the muscle, whichever direction, whatever muscle you're testing, you're going to shorten the muscle and find the position that decreases the pain of the trigger point the most. Now, you're going to hold that position while spreading the trigger points apart with your finger. You don't have to do that part, but it helps to spreading the trigger point apart helps to fix it even quicker. You're going to spread apart the spindle cells while the patient holds their breath. If the muscle is on the anterior side of the body, the patient's going to hold a breath in. If it's on the posterior part of the body, the patient's going to hold a breath out. If it's on the side of the body, just do a breath in too. Try it that way. Have the patient hold their breath for as long as they can. It should be about 30 to 40 seconds while you hold the muscle in that position. Once the patient can't hold their breath anymore, you're going to slowly return that muscle to its original length without the patient contracting it at all. A good way to do that is to go to the antagonist of the strain counter strain muscle you found and have the patient use that to slowly push into your hand to bring the muscle back down all the way. If the patient contracts it too fast, it won't correct what we're trying to fix with the strain counter strain of the muscle. So after fixing origin insertion, most common, maybe spindle cells, maybe GTO, after fixing those and going to the antagonist and to the synergist and correcting those, then we should have a well-balanced joint. Now the other type of problem we may have might be a compaction injury. This is where all muscles in the joint are weak except one. Now the one muscle that's strong, you're going to put that through patient active range of motion. You're going to have the patient bring that muscle through its range of motion about 10 times slowly and retest it, and that muscle will probably go weak. If it does, that's an indication for compaction injury type of therapy. Also, what you could do is if a joint is compacted, traction out the joint and see if all the muscles turn back on again momentarily. It's just kind of a challenge, but not a correction for the joint. So again, if we have all muscles weak except one, have the patient actively bring that muscle through range of motion about 10 times and see if it weakens. If it does, you're just going to do origin and insertion to that muscle, and that should correct the injury. Always go back after that and go back and check the occiput too. Sometimes you have a compaction injury like that, it will knock out the occiput, so check that also.